Okay, good morning everyone. Today we will continue with our presentation on the breast calcifications. What do we need to know? Will be the fourth and the final part, and by that you will have a 4-session presentation of 4 parts that explains almost everything you need to know about what to report if you see a calcification on a breast on a mammogram. Anything from macro to micro to dystrophic to whatever kind of calcification you see. So, as we were saying last time, the calcifications that are associated with malignancy, they usually develop in the necrotic cellular debris. When the cells start to die, these necrotic cells, the necrotic debris, they calcify. Okay, so imagine calcified necrotic dead cells. What would it will be like? It will be linear with some cliffs, irregular borders, reflecting what the active cellular proliferation. The cells are malignant, it's proliferating rapidly. So the calcification will be irregular, cliffs, branching, okay, with variable density. Some are dense, some are faint, some are in between. They can be focal, segmental, or regional, according to the extension of the necrotic process or the cellular proliferative process. Can be just in a breast segment, or can be a focal area or a region of the breast. They may have a linear orientation, can extend to the nipple if the ducts are involved, the same ducts. Mammographically, we usually estimate the extent of the disease fairly accurately. It's not like 100% accurate, but with a reasonable accuracy. We usually see the calcifications where the pathologists find the DCIS. DCIS means ductal carcinoma in situ, in case anyone doesn't know, which is like the earliest stage of the carcinoma, when the cancer cells are in the lining of the ducts. Okay, so when you see calcifications, there is the area to biopsy. Usually the pathologists find the carcinomatous cells there. Okay, so targeting this type of calcification, when you see this suspicious type of calcification and you do the biopsy from that part, what's called stereotactic biopsy, usually have a high diagnostic yield. It's a good diagnosis for the pathologist. Okay, these calcifications are molded in intimate contact with the proliferating cells because it's composed of layers. The necrotic layer, they usually calcify, and then the proliferating cells come. So they are in contact with each other. Sometimes associated round and punctate calcification may be seen among the linear calcification. So you might see benign calcification in addition to the suspicious calcifications. And the lesions that are characterized by central necrosis tend to be rapidly growing, and the calcification can change rapidly. If you do mammogram today, you do it after a short period of time, you can see difference in calcification. Why? Because sometimes the proliferating cells are proliferating rapidly. The calcification will change shape. This is a very suspicious behavior. If you do a mammogram today, you see some calcification. I'm not sure, maybe benign, maybe malignant. I can repeat the mammogram after a while, and after a while when you repeat it, the calcification is completely different. It's changing in shape, in size, in number, in density. This is a suspicious thing when you see a calcification that is changing. Okay, so focal increase in the round or punctate calcification in a given cluster, particularly if the cluster is in unusual location, you need to do a biopsy. If it is in some location that's not typical for benign calcification, if it is changing, you do a biopsy. For example, you can see here this is a metallic BB. You know, we said the metallic, something metal put over the suspicious area to localize it better. This is placed on the palpable area. There was a palpable area placed on it. There will be pleomorphic calcification demonstrating irregular, linear, round, and punctate forms. Okay? There are irregular calcifications in around irregular, linear, punctate forms with linear orientation. Some of the calcification are regional in this area. You can see this region is like locally involved. And by doing an ultrasound, you can see a hypoechoic macrolobulated mass, associated calcifications corresponding to the palpable area. Okay? So this is a suspicious mass. Okay? So excisional biopsy was done. There was some invasion with larger area of calcification on a tightly packed linear calcification. The ultrasound may demonstrate an associated soft tissue component sometimes. You see the calcification during ultrasound, you see some soft tissue component, and you can do an image guided biopsy from this soft tissue component. So if you see this type of calcification, if you see this ultrasonographic finding of a mass, irregular, heterogeneous, macrolobulated, what kind of biorads you give the patient? What degree? 4 or even 5? 4, 5, something in between. Okay? Why? Because these calcifications are regional. They are in a palpable mass, as we said previously. It was a palpable, and this BB metallic was placed over the palpable lesion. It is irregular. It is punctate, distributed in a regional pattern. On the ultrasound, you can see this macrolobulated. If it is macrolobulated, if it is hypoechoic heterogeneous, then it is suspicious. If it is a newly appearing lesion, it was not seen before, it is suspicious. You give it a BIRAD 4C, maybe 5. Okay? This is in a different patient. The MLO view, spot compression view, you can see pleomorphic calcification, linear forms, linear orientation. Okay, you can see irregular distribution. Okay, pleomorphic. There is no one shape. Some are round, some are branching, some are linear, some are a lot of forms. Pleomorphic. Okay, so again, if you see this kind of calcification, what BIRAD you give it? No, this is 3 is a 98%. I'm sure it's benign. Are you 98% sure this is benign? So you give it 4, even maybe 4C, 5, something in the high grade. You need to follow it closely. You need to take something, take a biopsy, whatever. Okay, do an ultrasound. You do something about it. Okay. This kind of calcification is suspicious, especially if it is in you. It was not there previously. The patient is palpating a mass was not there previously. Sometimes the patient says, I have a mass for the last 10 years. Okay, that's nothing there to be worried about. But if she said, last week I was examining myself, I noticed there is some mass there or here, this is the suspicious one you need to be careful about. Okay? And before you do your ultrasound exam, you palpate the mass yourself. Tell her, where do you feel it? She says, there, and you feel it by your hand to see the consistency, if it is hard, if it's soft. Okay? Again, here we have a case of DCIS, ductal carcinoma in situ. MLO view show mixture of high and low density linear round calcification. You can see the density is different, the shapes are different, and we said the suspicious calcifications are of variable density, variable shape. Okay? If it is of different shape, different density, unusual distribution, be careful. That's a suspicious lesion. You can see clefts in some of them. You can see this is cleft-like linear calcification. I think it's obvious here, right? You can see it, the clefting, يعني محززة. Okay? Also, we said this is features of suspicious calcifications. Although palpable, ultrasonographic evaluation was normal in this area. It was palpable by hand, but they did an ultrasound and there was nothing there. So you need to do a stereotactic biopsy under mammographic guidance, let's say, to be sure. This is a different patient, also spot compression magnification view. Demonstrate thin linear calcification with this is definitely suspicious. It's calcification of different shapes in a focal area of distribution in a newly appearing, not present before. So this indicates a suspicious kind of calcification. Okay, you need to worry about this, and this was a high nuclear grade ductal carcinoma in situ with central necrosis, and there was 1 millimeter focus of a grade 2 invasive carcinoma. even يعني DCIS plus some invasion, which is like bad. If you have invasive carcinoma, it's bad. Okay? Again, a different patient. There's this spot compression magnification view demonstrating many low density linear calcifications. You can see this, I think, there's tiny dots here and there. Linear calcifications, okay? Regionally distributed. These patients illustrate the variability that can be seen in the size and the density of the calcification associated with DCIS within and among the lesions. So all of these, this one, and this one, all of them are ductal carcinoma in situ, DCIS. All of them are high grade BI-RADS, like BI-RADS 4, 4C, 5. All of them are suspicious. However, if you see this is not like this, it's not like this, everyone has its own appearance. These are the kinds of calcifications you need to keep in mind, to be worried about. Here you have linear, you have some clefts, you have relatively different densities. Here it's more in a regional form, okay, and here it's more tiny calcifications. If you have this kind of calcification, just a word of advice, if you see this kind of calcification, check one thing, be sure of it. Be sure that your mammogram cassette is clean. This kind of density can be seen if there is dirt on the cassette. إذا الكاسيت وسخ. Okay, if there is any dirt on the cassette, okay, you can see this appearance of calcification and it looks suspicious. You will be in trouble. You'll do an ultrasound, there is nothing, the patient complains of nothing, but the mammogram shows some kind of calcification. It might be due to presence of some dirt on the cassette. Clean it well, be sure that it is clean, and confirm that with your radiographer, the technician. Then you report a suspicious calcification. This kind is, you can see it a lot with dirt in the cassette. Okay? Another example. This is a ductal carcinoma in situ, high grade with central necrosis. This was the MLO, oblique spot compression view, demonstrating punctate calcifications. I think you can see it here and here. It's punctate, it's focal, it's a little bit pleomorphic. They are somehow different shapes, okay? And you can see this are also spot compression views, magnification view after 6 months. First was this, okay? It was followed up after 6 months. What you can comment, compare the old one with the new one? What's your comment? They are increased, okay? Increase in number, increase in size, increase in density. They are evolving. And as we said, when it's evolving, when it's new, when it's changing, that's a suspicious lesion, okay? Now there are linear calcification surrounded by lower density round punctate calcifications. Here and there you can see it's different from this one, it's more prominent. So that's, you put again category 4 to 5, and on the high end of the 4. It's suspicious, it's developing, okay? And by surgery was done, the specimen was radiographed to confirm that the microcalcification was excised, removed, and it was a high nuclear grade ductal carcinoma in situ. Okay, so it's was very good catch, let's say. Now let's see this. This is a craniocaudal view, sorry, demonstrating scattered round calcification, okay, and some calcification here and there. It was recommended to follow up after 6 months. Okay, repeat the mammogram after 6 months. It's not localized, scattered here and there. Okay, follow up after 6 months. This was done, and what do you think? Compare this with this. What's going on? There are development of a new foci of calcification, some linear calcifications, and they are more numerous. Round calcification, okay? Right? So, spot magnification view with a stereotactic biopsy was done. You can see here, this is the stereotactic biopsy, the specimen mammogram to confirm that the lesion was excised. This is the first after 6 months magnification view and the specimen radiograph, and this was a high nuclear grade lesion characterized by more rapid time course with a short intraductal phase. It extends from the inside the duct, from ductal carcinoma in situ to invasive in a short period of time. Okay, if it is a low nuclear grade, it will take a long period to become invasive. High nuclear grade, it's short time it become invasive, and when it's invasive, that's bad. Okay. Another example. This is high nuclear grade with central necrosis. Again, the craniocaudal view showing some scattered tiny low density calcifications here and there, faint. Okay. 1 year later, after 1 year, few more have developed. If you can see, I think it's so on the viewer will not be very visible like this one and this one, and after a while it's developing, and after 2 years, again here it's more obvious. You can see this focus of calcification, it's more compared this after 1 year, after 2 years it's getting more. Okay, and then spot compression views obtained. Okay, the calcification are pleomorphic, variable density, and few linear forms. You can the same thing with a spot compression magnification view. It's much more. It is different shapes, different densities. It's localized. That's a suspicion kind of calcification. It's increasing in number, increasing in density, increasing in shape. Let's say in pleomorphism, indicating a BIRADS 4C to BIRADS 5 kind of calcification, something like that. Biopsy is indicated, and it was a high nuclear grade ductal carcinoma in situ. Okay. Follow up. You cannot make invasive procedure like a biopsy, for example, on every tiny spot of calcification that you. For example, if you have, just let me wait. If you have this kind of tiny calcification on a mammogram, you cannot do a biopsy for that. Okay, they're so common. We had 2 sessions just for benign calcifications. There are many lesions that can show this kind of calcification. You follow it up after 1 year. If it's increasing in number, increasing in shape, there is some mass developing, then you do the biopsy. شلون يعني history of previous CI? I don't know.
another breast عنده calcification وصار calcification by the
new appearing lesion new appearing calcification in the mammogram done now.
calcification مثلا in the another breast.
Okay, بالother breast هي مو
benign
بس اصبري.
and we will wait after 1 year to develop the ductal carcinoma inside, and after that we will.
When you see the calcification, the microcalcification, this is ductal carcinoma inside you. It will not develop. It is ductal carcinoma.
You say that this is
Just wait. اصبر ايش بيك؟ استغفر الله جنان. خلينا نحكي. وين شهادة previous mastectomy غير سوت ماموجرام وطلع الليجن وسوت الماستكتومي. من سوت دقيقة من سوت الماموجرام مو سوت البوث بريست. The other breast not mastektomized. هذا الكالسيفيكيشن اللي شفتيه هسه كان موجود بالاولد لو لا؟ فهمتيني؟ اذا كان موجود بالاولد then you compare increasing in size, increasing in number, increasing in density, that's suspicious. اذا ما كان موجود بالاولد again this is suspicious. فهمتيني؟ يعني هي من سوت ماستكتومي اصلا اكيد سوت بايلاترال ماموجرام صح؟ وبايوبسي وكل شيء وكل هالهوسه هاي. اذا كان الكالسيفيكيشن النيو اللي شفتيه هسه موجود بالاولد تقارنين انكريز لو لا لو ستيبل Stable, leave it. Increased, manage it. New low present before, إذا new, you have to do something about it. Get it? Welcome. I think we've seen that. Now, let's see another example. This is also high nuclear grade with central necrosis, craniocaudal view. This one, demonstrating low density punctate calcification. This might be benign, might be malignant, you don't know. If you have no old film to compare, you should follow it up. That's why the screening mammogram, if you're comparing with the old images, are of paramount importance. So important, very important. Okay? 1 year later, there are many more developing. Now it is suspicion. Make a compression view, magnification. I think it's very obvious. Pleomorphic, variable shape, variable density, increasing in number, in a focal distribution, and that's a very suspicion. And given the rapid evolution of the of this abnormality, a biopsy was done, and again it was a high nuclear grade ductal carcinoma in situ. Okay? Another example, ductal carcinoma in situ, intermediate nuclear grade with scattered areas of necrosis. You can see the craniocaudal view showing scattered punctate calcifications here, some scattered, not localized. It was followed up 4 years later. Okay? You can see more calcifications developing at the site. Compare this one with this one. There are more microcalcific foci. Spot compression views was done, demonstrating cluster of calcification with pleomorphism and variable biopsy, densities, and biopsy was done, and it was intermediate grade ductal carcinoma in situ. So you see, low grade, intermediate grade, you can follow it up for years, 3 years, 4 years, okay? Because it is low grade or intermediate grade, it grows slowly, okay? بينما high grade, while the high grade DCIS, it grows more rapidly in 6 months, maybe 1 year, okay? So the grade the comparison of the mammographic images done before 1 year, before 2 years, before 3 years, before 4 years, you have to compare all of them to get the final opinion. Okay? You need to have the whole file of the patient. Okay? The new one is not enough. If you do just read this mammogram, it's not enough. You need a follow-up. Okay? There is something called Vannewest prognostic index. I will not talk about it much, but just want to have an idea about what's that. It's a prognostic index that is used to facilitate the selection and the treatment options of the patient with DCIS. Okay? Score that is used to facilitate the treatment options for the patient. Every variable is getting 1 point, 1, 2, 3. If the tumor size less than 15, you give it score 1, margins more than 10, I don't know what. Everything you give it a score, and at the end, the score will give you what to do for the management of this patient. So to date, no statistically significant difference in the mortality rate were reported when the patient treated with mastectomy, lumpectomy, radiation therapy, or lumpectomy alone. There is no difference in the management. So what should I do? Should I recommend mastectomy, or just lumpectomy with radiation, or just lumpectomy? What should I do? Okay? While there is significant difference noted among these patients, the patient options with local recurrence rate are considered. If you are looking for local recurrence, there is a difference between mastectomy and lumpectomy. Of course, you'll have more recurrence with lumpectomy than with mastectomy. Local, not metastatic, I mean. So in many patients, the recurrences simulate the primary lesion, but about half of the local recurrence after conservative treatment of DCIS are invasive. Okay? The recurrent lesion is the same, the one that when you remove a lesion, okay, the recurrence is the same pathology, okay? But half of the recurrence are invasive. يعني واحدة عندها DCIS, you remove it, The recurrence is invasive carcinoma. Okay, so when you have a local recurrence, half of them will be a bad prognosis. The other half will be يعني DCIS again. فهمنا؟ So the recurrence is bad. It's worse than the primary in some of the patients. And in patients with ductal carcinoma in situ treated with mastectomy, the likelihood of local recurrence is almost completely eliminated. If you have a mastectomy, you remove the whole breast, بعد وين الريكرنس؟ صح؟ So this Vannewest prognostic index, if they have 10, 11, 12 points, they gain the most from post-lumpectomy radiation therapy. إذا البوينتس مالتهم سكور 10 11 12 ها best results from lumpectomy with radiation. تمام؟ Local recurrence rate are high, and these patients should be considered for mastectomy. If their score 10 11 12, very good results with local lumpectomy with radiation, but they might have local recurrences. Okay, so you need to follow them very closely, and any recurrence you just go for mastectomy immediately. You recommend mastectomy. Okay, just let's see this example. This ductal carcinoma in situ, low and intermediate grade with no necrosis, so that's good. No necrosis, low grade, intermediate grade. We can see here on the first we have an MLO spot compression view. There are some amorphous calcifications at the edge of the arrows here and there. Tightly packed punctate present, and spot compression magnification view of lumpectomy site 5 years after surgery. They did a lumpectomy here 5 years after surgery. You can see. Just a second. This is the specimen radiograph. They saw this on a mammogram. They did a lumpectomy, imaged the mass that's removed, and confirmed that the microcalcific lesion has been removed. Okay, and the site of the lumpectomy 5 years after the surgery, and there are 2 clusters of calcifications developing here and there. Okay, يعني البيشنت اجت عندها هاي الكالسيفيكيشنز. They did the surgery, removed it. They did an X-ray for the specimen, it was removed, confirmed. After few years, there are 2 foci of calcification developing here and there. Okay, again they are amorphous. This was a metallic clip from the previous lumpectomy. They put a clip to confirm, to show that this part is where the surgery done, and now we have 2 lesions here and there. Okay, ويايلو زين. Multiple clusters of tightly packed calcific foci طبعا removed. This was surgically removed, and there are multiple clusters of tightly packed punctate calcification. Many more calcifications are evident in the specimen. The appearance is similar to the initial presentation histology of recurrence was diagnosed. So she had this one, they removed it, 2 more foci developed, they removed them, and by imaging the removed specimen there are multiple foci of tightly packed calcification, which was recurrence. Okay, good. For the final few slides, I just want to talk about the artifacts or the mimicry of calcifications, things that can mimic calcification but they are not calcification, and these we should be very careful from, because they might put the patient in a very bad position just because of an artifact. We should be careful from them. Okay, they can sometimes present a challenge, like for example fingerprints, scratch marks, dust on the screen, deodorants, zinc oxide ointment, hair tattoo on the breast parenchyma projecting are more common artifacts that may simulate breast calcification. These things you should be careful about. Deodorants, lotions, fingerprints on the cassette dust on the cassette. These can look like calcifications or microcalcifications. Sometimes high density particles like shrapnels from gunshot wound or gold deposited bilaterally in the lymph nodes after treatment of rheumatoid arthritis. You know, one of the treatment of rheumatoid arthritis is gold salts, and these salts are absorbed and stored in the lymph nodes, and they might cause some high density calcifications that you see, you know, on a mammogram, but they are not due to pathology, they are just artifacts. Okay? For example, here they did this mammogram, and you can see there are multiple pleomorphic, variable shape, ill-defined calcific foci, and there was only a deodorant that usually seen where in the axilla. That's where you put the deodorant, on the axillary, and these appear as suspicious lesions on a mammogram. You should be careful from that. Okay, this was a different patient, sorry, and there were just some water droplets on the cassette. The cassette is wet from whatever reason. Some droplets, they look like this very suspicious appearance. Be careful from that. Confirm that the cassette is clean and the patient's skin is clean, and there is no, for example, lotion, ointment, deodorant, tattoo, whatever, on the skin of the patient that might look like this. Okay, and here it's a different patient with hair, just few hairs on the breast tissue. Okay, they appear like this, I don't know, confusing appearance. So even you might need to examine the patient yourself. Bring her to the room, to the examination room, and you examine the area that looks suspicious on the mammogram, see if there is anything wrong there. Okay? This is a different patient also. This was some kind of ointment called neosporin on the skin. And you can see there is some faint microcalcific foci here distributed in addition to this macrocalcific foci. Follow-up images after skin is cleaned confirm that the skin was just the skin was just an artifact. You compare this area with multiple microcalcifications, cleaning the skin, repeat it, and you have only these few macrocalcific foci of no clinical significance. Okay? Again, we are approaching the end of this torture, I think. نايمين. تمام. This was a shrapnel, شظير. Okay, just a high density material described the bullet trajectory, and the largest collection of the shrapnels were photographed, and the density is much higher than that seen with the breast calcification. You don't see breast calcific foci this dense, so dense, and if you notice, all of them are of the same density. They are not of variable, not faint to high density. They are all of the same density. Okay, indicating that it's not very significant. And when you see this shrapnel and multiple pieces of it in the adjacent breast parenchyma, confirming طبعا with the clinical history, you confirm that this is just an artifact. Okay, and that will be the end of our presentation on the mammography of the calcifications of the breast. I hope it was beneficial. Now you have 4 parts. It will be published on the YouTube if you want to review it all. We have presented over 120 slides maybe of different kinds of calcifications: benign, malignant, artifacts, large, small, suspicious, non-suspicious. By now you should be able to at least tell which patients to follow up, which patients to biopsy, and which patients to send home. At least that. These kinds of calcifications should be just sent home. These are worrisome, should be followed up. These are very suspicious, need to be biopsized. And you need to know at least what to say when you are discussing this with the surgeon. When you have a mammogram with this appearance of different kinds of calcification, you must know what to say and what to tell the patient and what to tell the referring physicians or the surgeon. You call him and tell him this is nothing, send her home, this is needs a biopsy, this needs a surgery, this needs a radiotherapy, you according to the situation. Okay, the most important thing that I should insist on, always have the previous images, always compare with the previous images. The previous images is the key, and confirm with your technician that the mammographic image is taken properly. The cassette is clean, the patient is clean, the views are proper, and compare with the old images, okay, and do the whole thing, whatever you need, an ultrasound, an FNA, a biopsy, consult with the surgeon, examine the patient yourself, whatever you need to do, just do it, and get the final diagnosis. Because ductal carcinoma in situ, it's a very, I don't know, very something not so risky. It's a relatively good thing. But if it is developed to invasive, then the trouble begins. And this depends on your report. Okay? Any questions, any comments? Thank you very much.